Pharmacology SAQ11 classify the drugs commonly used for aspiration prophylaxis, elaborate on their mechanisms of action and adverse effects, 10 marks. These include gastrointestinal stimulant or prokinetic agent such as metoclopramide, gastric acid secretion inhibitor such as H2 receptor antagonist ranitidine, and non-particulate antacid such as sodium citrate. Metoclopramide. Actions. Metoclopramide is a substituted benzamide and a dopamine antagonist. It exerts its anti-emetic effect by inhibiting D2 receptors in the chemoreceptor trigger zone. It also acts as a 5-HT3 antagonist. Metoclopramide augments acetylcholine release and sensitizes the muscarinic receptors along the GI tract. It is a prokinetic agent via its peripheral cholinergic actions. It increases the lower esophageal sphincter tone via peripheral cholinergic action and causes relaxation of the pylorus. There are no effects on gastric secretion. Metoclopramide improves coordination of gastric, pyloric, small intestinal motor function. Metoclopramide reduces the sensitivity of visceral afferent nerves to local emetics and irritants. Onset of action 1 to 3 minutes. Duration of action 1 to 2 hours. Metoclopramide adverse effects. CNS. Extrapyramidal effects may occur due to its anti-dopaminergic activity, such as dystonia or oculogyric crisis. Neuroleptic malignant syndrome and sedation may occur. Potential CVS effects include hypotension, acute hypertension in pheochromocytoma, bradycardia or tachycardia. Metoclopramide increases prolactin production, and this may result in galactorrhea, gynecomastia or amenorrhea. Metoclopramide inhibits pseudocholinesterase and may therefore prolong the effects of drugs metabolized by this enzyme. Metoclopramide is porphyria unsafe. If taken chronically or in high dosage, may cause methemoglobinemia or sulfhemoglobinemia. Metoclopramide crosses the blood-brain barrier, placenta and breast milk, and can precipitate extrapyramidal side effects in fetuses. Next is gastric acid secretion inhibitor ranitidine. Ranitidine actions. Ranitidine binds competitively and reversibly to H2 receptor on basolateral membrane of parietal cells. This prevents CAMP-mediated activation of hydrogen-potassium ATPase. This reduces acidity and volume of gastric acid. Onset of action is within 30 minutes via IV route. Duration of action is 10 to 12 hours. Ranitidine is better absorbed and more potent than cimetidine with fewer side effects. Unlike cimetidine, ranitidine does not inhibit hepatic CYP450 enzymes nor interfere with metabolism of other drugs, nor cause anti-androgenic effects. There are no effects on gastric emptying time, lower esophageal sphincter tone, the fetus or labor progress. Ranitidine adverse effects include cardiac arrhythmias with rapid administration, accumulation in renal failure and toxicity unless dose adjusted, liver dysfunction. Discontinuation is associated with rebound hypersecretion of gastric acid. Thrombocytopenia, leukopenia, anaphylaxis may occur. Ranitidine is porphyria unsafe. Oral ranitidine decomposes when heated to NDMA, which is a probable human carcinogen. Third is non-particulate antacid such as sodium citrate. Actions of sodium citrate. Citrate is a weak base and it neutralizes gastric acidity by reacting and removing hydrogen ions in the stomach. 30 ml of sodium citrate neutralizes 255 ml of hydrochloric acid with a pH of 1.0. Onset of action is faster than particulate antacids due to more complete mixing with stomach contents. Duration of action is typically 30 to 50 minutes. Effective duration is variable and depends on gastric content and emptying time. Risk of pneumonitis is small if aspirated, unlike particulate antacids. Adverse effects are minimal. Nausea, vomiting, diarrhea, and stomach pain may occur. Metabolic alkalosis may occur if taken in excess.